16-inch catheter.
So after listening this history, examiner may ask 2-3 questions. That is, what is the definition of nocturia by current International Incontinence Society?
One or more than one time in the night is defined as nocturia.
That is old definition. So going once also, one or more than once also, it is nocturia.
Okay.
Then second question may come from examiner as how you calculated IPSS score. It is easy, but that question may come in exam. Then what is meant by mild, severe, and moderate type of IPSS score, and what is its clinical importance? These are the two simple questions, but you should be ready with these questions in the exam particularly.
So, sir, Dr. Gite sir, just to add, just saying one or twice is not important. What you need to say is that patient would pass urine one or more times, and that should be preceded and followed by sleep.
Exactly.
Only then it is called nocturia.
That is a classical definition of nocturia.
So somebody can take over the question. What is mild, moderate, and severe symptoms as per IPSS?
So a score of 1 to 7 is mild, 8 to 19 is the moderate, and 20 to 25 is the severe IPSS score.
Another question. Yes. So another question, patient had a painful retention. So my question to you is, how will you divide acute urinary retention? Or what are the predisposing factors, or what are the types of acute urinary retention?
It may be spontaneous or precipitate acute urinary retention.
Exactly.
Sudden onset or precipitated.
So it should be sudden onset, it should be painful, and it should be precipitated by something or spontaneous. So what will precipitate the things? For example, immobility of the patient. For example, severe pain. For example, opioid analgesia. For example, anesthesia. For example, over drinking alcohol. For example, sympathomimetic drugs. For example, anticholinergic drugs. So these are the things which can precipitate. And in 50% of the patient, it is spontaneous. So this is the acute urinary retention. Then what, if examiner want to ask what is the chronic urinary retention?
When chronic urinary retention is when there is painless, there is patient can, even after passing urine, there is palpable bladder.
How much urine should be there in the bladder to call it chronic retention?
300 ml or more.
More than 300 ml.
Right. And for chronic retention, again, I would go a bit theoretical here. The definition has that this should be checked at least twice over a period of 6 months. So not only it says that there should be more than 300 ml residue, but to call it chronic, the duration should be 6 months. So this is being done to exclude patients, say, like sir gave an example, somebody has an anesthesia and has a painless retention after that, is carrying 300 plus ml residual urine. That cannot be called as chronic urinary retention because it's a very short duration retention.
Exactly. So chronic urinary retention is again of two types, high pressure bladder and low pressure bladder or low pressure chronic urinary retention. In both, there is bilateral hydronephrosis, but associated renal dysfunction is present only in the high pressure chronic urinary retention. Okay. And in low pressure chronic urinary retention, bladder is usually a floppy and no upper tract dysfunction. But on sonography,
Fine. And Achin, can you just summarize this whole history?
Sir, a 74-year-old male patient which came with complaints of difficulty in passing urine since 6 months with one episode of acute urinary retention 5 days back, and he has been on catheter since then with a known case of hypertension and ischemic heart disease, and with IPSA score of 12/35 and bothersome symptoms of 3.
And he has not taken any treatment for enlarged prostate.
Without on any treatment for lower urinary tract symptoms.
Okay, fine. So now next what do you like to do?
First, sir, a clinical examination, sir.
Okay.
I would like to.
Tell us what are the things you'll do.
Sir, I would like to assess the patient as a whole. I would like to assess about his conscious, cooperative, available to time, place, and person or not. His vitals, namely pulse, BP, and sir, respiratory rate and SpO2, sir. Then pallor icterus cyanosis, evidence of pallor icterus cyanosis, clubbing, lymphadenopathy, or edema has to be seen, and head to toe spine examination has to be done, sir. And what is his performance score, namely in the terms of Karnofsky score or ECOG score, sir. And then local examination, sir, mainly per rectal examination since he has presented with lower urinary tract symptoms. And then, sir, general system examination per abdomen and CNS and RS.
So per abdominal examination is important. Per rectal examination is important, and focused neurological examination is also important, including all whatever you have told already. Okay. So what are the things you will see or chances of you will see on the per abdominal examination?
Per abdominal examination, sir, inspection wise, we will look whether there is initial any scar marks, sinuses, or engorged veins are present, especially any suprapubic catheter scar is there from beforehand, and whether all cauldrons are moving equally with respiration. And palpation wise, patient already is presently patient is on catheter only, so I'm not suspecting any bladder lump, and any tenderness is there suprapubically, and we have to auscultate for bowel sounds.
Okay, this patient had after placement of catheter, there is a hematuria.
Yes,
so how will you manage post PUC hematuria in acute retention?
Sir, firstly, I will likely like to assess whether it's gross hematuria or minimal hematuria post catheterization. Whether the hematuria has its blood per meatus, per urethral meatus around the catheter or within the urine bag, and how much amount the urine hematuria quantity is there. And if still it's highly concentrated, it's frank hematuria, I will give a bladder wash then and there, sir. And if possible, since this person has already 16-inch catheter was easily negotiated, I will change it to possibly 20 and start the irrigation. And then further on.
Anchit, why there is hematuria?
Hematuria can be of due to several reasons, sir. It could be due to pre-existing urethritis since we have passed catheter. It could also be due to enlarged prostate because of the increased microvessel density in the prostate, and the catheter must have gone. Or secondly, lastly, sir, due to the sudden decompression of the acute renal retention, there could also be hematuria because of
So
the capillary bleeding.
in this patient, you have forgotten the history. There is a significant history. Whatever you have told, that is a primary. That is sudden decompression of the distended bladder and friable hypervascularity in the submucosa got torn, distorted, and that will lead to the hematuria. That is one thing. What was the hypothesis? Another is he had a history of taking some.
Blood thinner, sir. Ecosprin is
Yeah.
already a known case of
So
CABG.
these are the two things. So first thing is commonly what happens in such type of patients. So prevention is better than cure in a chronic urinary retention or acute urinary retention with over distended bladder. There there should be a slow decompression of the bladder. If you suddenly decompress it, then there is submucosal vessel get torn or distorted, and there is a bleeding. And whatever the bleeding initially conservative line of management, plenty of oral fluids, IV fluids, 3-way fluids, catheterization, and then injection, tranexamic acid, if it is required. These all things you should know in the management of the post-PUC hematuria.
Yes.
So next comes is a PR examination. So tell me in details about PR examination. What you know,
Yeah.
everything about
Dr.
PR.
Gite,
Yes, sir.
before we go, just more physiology about the chronic retention. See what happens when there is a chronic retention, there is an increased intravesical pressure. This is transmitted to the superficial veins of the submucosal veins in the bladder. So the pressure in normal vein is 0, but here the pressure is increased. And because of the stretching, the vein wall has become thin. Now sudden decompression means the pressure outside the veins in the bladder is now going towards the 0, while the pressure in the vein is more than 0 and the walls are thinned out. So that is why it ruptures and it causes bleeding. So this is what you see in a chronic retention of urine.
Yes.
Okay, now go ahead with the per rectal examination.
Should I answer, sir?
Yeah.
Let Ajinkya, you want to answer?
Yes, sir. In rectal examination, I like to do the inspection of the perineum to see if there is scars, any fistula tracks, hemorrhoids, any skin tags. And then on rectal examination, I'll first explain the patient the procedure, what I'm going to do, and then I'll take the patient into the position. And then with the gloved hand with the lubricated, I like to do a rectal examination. On rectal examination, I like to look after the following things. One is the whether the rectum is loaded or not loaded, any palpable mass in the rectum. Then I'll also like to see the consistency of prostate, surface of the prostate, whether I could go above the prostate, the median sulcus, the lateral sulcus of the prostate, the mucosa over the prostate, and then I'll also, after taking out finger, I'll look to see whether the soiling or any blood on the tip of the finger.
So you don't want to do local neurological examination?
Yeah, local neurological examination.
So how will you do it?
So perineal sensations, BCR.
Anal tone.
Anal tone.
Perineal sensation.
Anal tone, yes.
Yeah. So whatever I told before, that is slow decompression. This is a hypothesis not proved by various studies, but practically it is helping in day-to-day life. So you should know about that. But if some examiner asks, is it literature-wise proved? So it is not proved. Okay. As far as prostate is concerned, then you must know the DR examination grading of the prostate. That can be asked. Another thing is size of the prostate, contour of the prostate, consistency of the prostate, mobility of the mucosa overlying, then protrusion inside the lumen of the rectum, then pain while during the palpation to reach above the prostate, upper border of prostate, and these all things are important. So I will think what is the normal consistency. Person will tell you it is what is normal consistency.
Firm, sir.
Tip of the firm
So
to
rubbery
Yeah.
or firm. So how you have compared this with What part of your body?
No.
Thinner
Tip of
element.
No, sir.
or the
Thinner pad of the thinner pad or tip of the nose, or rubber, that is pencil eraser. That all three can be compared with the prostatic consistency. So, focused neurological examination already we have discussed, but that should be definitely told in case of whenever you are suspecting any pathology related to the prostate. So, provisional diagnosis.
And one more thing, Dr. Gite, how to compare with the volume?
Yeah. That is another thing. Grade 1, grade 2, grade 3. What is by grade 1, grade 2, grade 3?
So there is Barney's classification, sir.
Hmm.
Grade 1 is there are Barney's as classified in this 1959 study into grade 1, 2, 3, 4, sir.
Hmm.
And more than 2 centimeters is grade 1, 3 to 4 less than 2 centimeters is grade 1, 2 to 3 centimeters is grade 2, 3 to 4 centimeters is grade 3, and more than 4 centimeters is grade 4, sir. And we compare with the pulp of the finger, sir. And this
So, three classifications. One is sonography classification. One is DR related classification. Another is endoscopic classification. And another is endoscopic IPP classification. That is intraprostatic protrusion, intravesical protrusion of the prostatic median lobe. This all you must know. Anything can be asked in exam.
One of the simple way is just remember, next time you go to OT, just inflate the balloon. Cooley's catheter balloon, 5 cc, 10 cc, 20 cc. And you see how much enlargement is there of the balloon and put your finger on that. And you will come to know. So next time when you do colorectal examination, you will be able to correlate it. And in your mind, you will be able to find out how much cc this prostate is, the size is. Fine. Okay. Paras, Maheshwari ji, आपको कुछ बोलना है?
No, probably he may have left, sir.
Okay. So Paras, go ahead.
आप एक मैसेज कर दो सर, शायद गलती से लेफ्ट आउट हो गया.
I'll find out.
Okay, Paras, go ahead, please. Paras.
So on general examination, patient is conscious, cooperative, well-oriented to time, place, and person. The vitals are stable. Patient is afebrile. Saturation is 98% on room air. No evidence of pallor, icterus, cyanosis, clubbing, lymphadenopathy, pedal edema. Head to toe spine examination is grossly normal.
Go ahead.
Per rectal exam, external genitalia examination, external genitalia normal, non-circumcised. Patient is non-circumcised, penile meatus is normal, all hernial orifices are normal, scrotum, bilateral testes are palpable and normal, non-tender, there is no sign of any fluid collection. On per rectal examination, there is no sign of fissure, fistula, hemorrhoid, anal tone is normal, grade 2 prostatic enlargement, firm in consistency, smooth surface, non-tender, rectus mucosa over the prostate is mobile. There is no fecal loading, no blood on gloves. Abdominal examination, it is grossly normal. No significant find. Respiratory, CVS, CNS, all are normal.
Fine. So Bhargav, who is a third person? Bhargav, na?
Yes, sir.
Bhargav.
Yes, sir.
Yes. So Bhargav, this is the examination. Now, next, what you would like to do?
Sir, I would like to investigate with routine blood investigation in form of complete blood count and RFT and ultrasonography of the kidney, ureter, bladder, and the prostate region, sir.
Okay.
And
Fine.
urine routine also.
Anything else?
I'd like to have sir, uroflowmetry of this patient. Sir.
Patient's catheter, sir.
Uroplometry
Patient
is
is on
the
catheter,
off
so
catheter.
Okay, sorry. Sir.
Serum PSA.
Okay. So now what is the status of serum PSA? In all the cases you do PSA? See, in India, if you go to see other EU and EUA guidelines, they are not recommending. But in India, we are doing routinely PSA. So many of the examiners, they will like that you say that PSA is to be done. Dr. Gite, what is your view? In exam,
Sir, until and otherwise, but doing a PSA is not mandatory until and otherwise it is really indicated in the exam. That is, suppose, for example, on DRA there is a nodule is palpable. Suppose any signs and symptoms, constitutional symptoms of prostate is shear prostate is present. But offering a PSA to each and every patient is advisable. Okay, doing is not compulsory, but offering a offer to do a PSA is advisable as a screening protocol. In this patient how patient had a recent history of acute urinary retention, patient had a history of parietal catheterization, so chances of having there is infection is always there. Then chances of size of the gland, how much is the, so PSA should be correlated with the history of catheterization, history of retention, then size of the gland, age of the patient. All these factors will impact on the amount of PSA displayed after doing the examination. If you ask, and again, if the patient is suppose 80-year-old, more than 75-year-old, so his remaining lifespan is not probably less than 10 years. And again, it is not needed. If you are not asking for PSA, you have to defend it. If you are asking for PSA, then also you should able to defend it. This is my step.
fine. Okay. Paras, show the results.
So on urine routine microscopy, WBC cells are 80 to 100 per high power field. RBCs are 60 to 80 per high power field. There is a presence of albumin +1. Urine is acidic, no crystals present. On culture, there is no growth.
So there is hematuria, proteinuria, and pyuria probably. Am I correct, Paras?
Yes, sir. The hemoglobin of patient is 14, TLC is 8800, blood group is V positive, creatinine is 0.82, PSA is 0.78.
So hematuria means what it is? It may be due to BPH, it may be due to shear prostate, it may be due to stone, it may be due to
infection.
drug induced, it may be due to infection. Pyuria is superadded UTI. Proteinuria, then it is probably associated medical renal disease. So when Achit or Bhargav, when you want to do upper tract imaging along with sonography, indication.
The upper tract, when sir, the post in a person when a postward urine is more than sir 300, and sir, there is a creatinine is high in this patient. The creatinine is normal, and sir, we are suspecting chronic obstruction, sir. So to rule out any damage to the upper tract.
Upper tract imaging means what?
Ultrasonography or CT.
Of kidney.
So whenever
Kidney and ureter.
ultrasonography suggests anything related to the upper tract is getting damaged, like associated hydronephrosis. Okay. Patient presented with hematuria. And again, there is indication for upper tract imaging. Okay. So these are the some typical indication for upper tract imaging. Another thing is someone has asked in
what is the importance of hematuria. So that is what we have explained. Why there is a hematuria? What are the causes after catheterization?
Relevance of hematuria on urine routine examination when patient is on catheter. So getting a 3 to 4 RBC may be relevant to the relevance to the catheter. But here, how much is the RBC per us?
80 to
60
100,
to
sir.
80. 60 to 80.
60 to 80 RBC should not be due to the catheter. Another one question asked, why there is hematuria in BPH?
Because of increased microvessel density in
Microvessel.
prostate, sir.
Exactly.
So the sonography, Paras.
Yes.
Can you just enlarge?
Yeah.
Okay. Who will like to read?
I'll read, sir.
Okay. Tell us.
Here we can see clear cut, sir, smooth walled bladder, which could be partial, completely full, because considering the catheter should be clamped, and we can see the catheter balloon with the Foley strip within the catheter, sir, within the bladder, sir. And prostate cannot be distinctly visualized. Only the part of prostatic fossa or the bladder neck can be seen, sir. They have marked it, the dimension, so I cannot read, sir. And kidney, sir, right kidney is reniform in shape with corticomedullary differentiation well maintained with smooth lines. And left kidney shows a hypoechoic lesion, probably cyst, sir, or it could be a dilated calyx. However, there is no obvious gross hydronephrosis.
There is none.
Yeah. So someone has asked, can you comment on bladder wall? Partially distended. So when can you comment?
Bladder wall thickness, sir, in collapsed bladder, the bladder wall thickness should be around 3 mm, 3 to 5 mm, and in a full bladder, it should be less than 3 mm, sir. Normally, in more than 3 mm in completely full, and more than 5 mm in partially full or collapsed bladder is considered as bladder wall, increased bladder wall thickness. And here, so I don't think there is considerable bladder wall thickness.
So,
So
at
Dr.
what,
Pankaj,
at what bladder
Pankaj,
volume?
can you unmute yourself?
Yes, sir.
Yeah. So please, you give your whatever your answer is.
Yeah, you see, never comment on bladder wall thickness when the bladder is not 250 ml full. So like in this patient, I will not comment on bladder wall thickness. If the bladder is not adequately full, the bladder wall will always look thicker. By convention, to comment on bladder wall thickness, the bladder should be full between 200 to 300, optimally 250 ml. Okay. So at 250 ml, you should have a bladder thickness which is less than 3 millimeters. If it is more than 3 millimeters, then it is considered as significant.
Exactly, because after the 250 ml, in various studies, there is no change in bladder wall thickness. Up to 250 ml, bladder wall thickness measured at 50 ml, 100 ml, 200 ml, and 250 ml, it will change. But after 250 ml, there will not be any change in the bladder. Actually, it should be measured at the volume of bladder as to.
Yeah. So, Dr. Gite, can you
Sir.
just in one line, Ameya has asked, can you repeat the causes of hematuria in such
Hematuria.
cases? So can you?
Hematuria here, BPH, stone, CA prostate, drug induced. These are in this such particular type of patient, these are the common causes for hematuria, lower tract causes for hematuria. Again,
Okay.
miscellaneous like malignancy also. Malignancy of the prostate, malignancy of the bladder, then stone in the bladder, benign enlargement of the prostate, and drug induced. Again, there is a miscellaneous or rare causes. Hematuria may come from above, rarely. So TCC of the ureter, TCC of the renal pelvis, then RCC involving pelvic calcium system. These are the AV malformations, fistulas, hemangiomas. So the ruptured hemangioma. These are some rare causes, but basically it is prostate, CA or benign, stone, CA bladder, drug induced in this patient.
Fine.
Okay, coming back to this
So-
sonography, I would also comment here, like if you look at the second image, the balloon appears a bit away from the base of the bladder, which shows that probably there is an intravesical prostate protrusion. Okay, if you can enlarge this second image, let's look at that image
Yeah.
properly.
Paras, the above one, the first line, second image.
Yes, the same one. Yes, can you appreciate now? The
Yes,
prostate is growing in here. We can see that the balloon is away from the floor of the bladder.
Yes.
So, what is the significance of IPP?
IPP will tell you the progression of disease patient will face.
So, what is the grading of IPP?
Is grade 1 is less than 5 mm, grade 2 is 5 to 10 mm, grade 3 is more than 10.
So, the larger the IPP, higher is the possibility of this patient ending up with retention or rather having progression of the disease.
Progression of the disease.
The second importance of IPP is that if significant IPP is there, then this is one patient where you would not want to give voiding trial, or rather the voiding trial is likely to fail. And there is also some recent data which says that in significant IPP, dutasteride may not have much effect. So these are three significant things related to IPP. What are the other things you look at in sonography of bladder to comment on bladder outlet obstruction?
Angle of the prostatic angle.
What does that mean?
There is we draw a line through the prostatic urethra and then another line through the prostate, and it should be obvious. It should not be more than 35 degree. If it is more than 35 degree, it suggests bladder outlet obstruction.
Excellent. What else?
Another is bladder weight, which we calculate.
So how much should be the bladder weight and how is it calculated?
Bladder weight is usually calculated. We take two, there is the outer bladder wall thickness and the inner bladder wall thickness, and we subtract it, and it should be less than 35. Oh, sorry, more than 35. It suggests bladder outlet obstruction.
So again, you'll have to say here that the bladder wall weight is calculated at 250 ml bladder fullness. Okay. And as you rightly said, two lines are drawn inside and outside, and the difference between the weight of the two is calculated. Anything else?
Calculations of the bladder wall.
PCAR can be taken.
Let's talk of commoner things first. Associated diverticulums.
Associated.
Yeah. So these are advanced things, but simpler things will be irregular thick bladder, associated diverticuli, associated upper tract dilatation would mean that the obstruction is severe. And yes, then all these things will come in.
Yes.
So someone has asked what is meant by angle. So it is a prostato-urethral angle. Okay. Another question someone has asked earlier on.
In the simple words, sir, you can explain them that if the prostate, the angle between the urethra and the prostate is more, means it is causing the obstruction of the outlet. Second thing is someone has asked about the volume. So it is like in the arithmetic we were asked, if there is a square and you have to make tiles on its at the edges, and then you take outside perimeter and inside perimeter. The same thing is calculated over here, the bladder wall outside and inside. So when you subtract, you get the bladder volume.
Bladder weight, sir.
Bladder weight.
Sorry,
bladder weight.
bladder weight. Yeah. Fine. Okay, go ahead. Pankaj bhai, you were asking some other questions, radiological.
Hey, somebody had just mentioned about PICAR, so I was quite, if they can explain what PCR is.
PICAR is, sir, we compare the shape of the prostate with the spherical shape, and I don't know the
So
other
you look
details,
at the
but
largest diameter of the
large
prostate
diameter.
and draw a circle of that diameter and superimpose that circle over the prostate shape. If it covers more than 81% of the bladder area, then that is supposed to be more obstructive. I think it is PCR, not PICR.
Okay. Can during the class, can someone just find out and let us know? We'll go ahead. Fine. So Ajinkya, now next what you want to do? So looking at this sonography, what do you think? What do you think about this prostate?
Prostate is enlarged, sir, because upper tracts are normal and bladder is also normal.
Okay. So now next what you want to do? This is the first retention.
Yes, sir.
Yes.
So you want to give him a trial or you don't want to give him a trial?
We can give him a trial, sir.
Was he on
Not on
treatment
any
for
previous
the?
treatment.
Not allowed.
So what type of medicine you want to give him?
So considering the age of the patient and the retention for the first time, I think silodocin will be better for this patient. We will continue silodocin for at least 72 hours, and then we can give a catheter trial.
Why you want to give silodocin?
That is fast acting, sir. Can give alpha-docin also, but silodocin is.
So effect comes within how much time?
So it has percentage-wise effects. If it nahi.
Silodocin action starts within 6 to 8 hours, and full action comes within 3 to 7 days.
Okay. So why silodocin? What are the advantages in this patient?
It has least effect on cardiovascular. Patient is a known case of CABG. Already he's on terazosin. Already he's on telmisartan and other antihypertensives. So as a urologist, I could choose the safest drug having least cardiovascular side effects. So we have chosen silodocin or tamsulosin.
But tamsulosin, compared to tamsulosin, silodocin has got better effect on acute retention of urine. These are the studies which are shown, correct?
Yes, sir.
So you will like to give silodocin. Any other drug along with that?
The 5-alpha reductase inhibitor,
Alpha.
I would like to add, because the prostate is more than 40 gram. It won't help in the catheter-free trial because it acts on the static component, but still we'll start with a combination therapy.
What are the indications to start combination therapy? Why not only silodocin?
Sir, due to the 5-alpha reductase inhibitors act on the static component, and they act over a period of time, mostly 3 to 6 months.
My question is when you will start combination and you will start only single tablet, that is alpha blocker. Selective, super selective, as per convenience, up to your convenience.
Sir, alpha blocker is mainly targeting the alpha receptor. We add 5-alpha receptor when the prostate volume is more than 40 grams.
And
immature.
and
Any relation to PSA?
so
More
as
than
per the guidelines, the prostate size should be 40 grams or grade 2. PSA should be in some book it is 1.4, in some book it is 1.6. Old books. Post-void residue should be near about 100 ml. But what we routinely practically consider, it should be more than 1/3 of the period. And Qmax should be less than 10 ml per second. So either of these things, if in single or in combination present, then only there is a need of starting the two drug therapy, that is 5-alpha reductase as well as alpha blocker. And if it is only for less than 40 gram prostate and all other things are negative, then single drug is suffice as a medical management.
Yeah. Dr. Hudedar, you want to comment anything? Fine.
So
Okay,
if you have decided to give a trial without catheter, means what instructions will you give to the patient? How will you plan the trial without catheter?
I should answer?
Anybody
Yeah,
who
yeah.
wants to answer. Yeah.
Firstly, sir, we should discuss with the patient, considering the ultrasound finding already showing intravesical projection and prostate is already of 55 grams. We should discuss with the patient that there may be chances of failure of this catheter-free trial. So you may end up with requirement of the surgery. However, since only it's the first episode, we can give a catheter-free trial, and it should be given within like after 72 hours.
So what instructions will you give to the patient when the patient comes for a catheter-free trial?
Catheter-free trial, sir. Firstly, the previous night dose of the combination therapy has to be taken, sir. And he should be well hydrated. And sir, no increased fluid intake over a period of time. Sometimes people do so in order to avoid they take more fluid, that it actually ends up in precipitation of the
So alpha blocker for a minimum period of 72 hours. There should be no constipation, and post catheter removal, instruct him that he should not suddenly drink too much liquids. It should be small amount at frequent interval. Excess sudden liquid may precipitate retention, as you rightly said. Very good. Somebody is in this. There is a question: is there any role for urodynamics in this test in this patient?
I don't feel there is any role of urodynamics because, sir, a patient with low urinary tract symptoms, urodynamics are primarily indicated when the post-void residue is more than 300 or the voided volume. Well, this patient is catheterized, but in other patients, if the post-void is more than 300 ml or the voided volume is less than 150 ml, or extremes of ages like less than 50 years of age or more than 80 years of age, or we are suspecting any neurological symptom, but he is neurologically fine, so we need not have urodynamics in this.
Good.
Also, patient had acute painful retention, so I think there is no need of urodynamics.
We are not suspecting any chronic retention.
And any patients associated with any one of the neurological disorders.
Yeah.
Like CVA, Parkinsonism, diabetes,
Yes.
chronic diabetes, I mean, chronic uncontrolled diabetes.
Fine. So Paras, tell us the history, what happened? So
Patient
what
was
type of
started on alpha
node,
blocker and catheter-free trial was given after 3 days, but the catheter-free trial was failed. So patient was taken up for TURP after preparation.
Because
So-
here here we want to discuss and make a consensus. What is the routine practice of doing a catheter-free trial as per the guidelines and practically as per the consultants? Like single day, there are now a number of literature. Single drugs for 3 days, combination drug for 3 days, single drug for 7 days. So, what exactly should be followed, and what exactly should be told as per the guidelines? Pankaj sir.
Sir, minimum 3 days, optimally 7 days.
Can you elaborate? Dr. Gite has given some suggestion.
Because few centers giving only single tablet, and after they were giving the trial. There are
Single
some
tablet will not work at all, and you need to give time. As it is, you see, once the patient has landed into retention, the one of the concept for waiting is also you need to give time for the whatever stretching the detrusor muscle has gone through. You need to give time for the muscle to relax in a way. So 72 hours is the optimum time to wait. In this period, you would cover him up with alpha blockers. Also,
Yes.
if there are any precipitating factors like any drugs, constipation, those will be taken care of in this period.
And to
Yes.
that, you can add some that you like to give some antibiotic and maybe some anti-inflammatory like in form of serosopeptidase, chimeral form, just to reduce the edema.
So all these things are sir, hypothetical and practical as per the consultants. Like giving alpha blocker, giving a prophylactic antibiotic as there is a catheter or expecting infection. So without doing a urine culture, so all these things can be given practically. But as far as the exam is concerned, as sir told, it should be minimum 3 days, and if you told 7 days also, it's okay, but not less than 3 days.
Okay. So what type of surgery you like to offer?
Should I answer?
Anyone can answer.
Sir, is considering the age of the patient 74 years with history of CABG already on blood ecosprin and prostate size of 55 grams, we can offer mostly minimally invasive surgery in the form of either HoLEP or THOLEP or monopolar TRP or bipolar TRP, considering we have achieved cardiologist fitness. And if he says that ecosprin can be stopped, then we'll go ahead with monopolar TRP. We can go ahead with monopolar.
Anyone else? Bhargav, what do you like to do?
Yes, sir. I would like to go ahead with a monopolar TRP or bipolar TRP after taking fitness from the cardiologist.
Okay. But what you will prefer? Suppose if
Then
you have got all the facilities and you can do all the surgeries.
Sir, I will prefer bipolar TRP in this patient, sir.
Anyone else? Ajinkya?
So considering the age of the patient on blood thinners, we can use KTP laser here.
How age of the patient is going to decide the type of treatment?
No, sir.
It has to be minimally invasive. Well, it's not absolute, but relative.
So, if it is P80, for example, so how it will change? Having a history of taking antiplatelet drug, that may change. Size of the gland may change the planning of your type of treatment. Associated comorbidities come along with that particular age may change the planning of your treatment. But age as a solo factor may not be of that much importance.
Yes.
So I think Achintya has given a very good answer. Either you can do HoLEP, THOLEP, monopolar or bipolar. So that is the way it should go. Fine. Dr. Udedar is there. Anil, you want to add anything? Dr. Maheshwari, you want to comment? Otherwise, we'll go on a different scenarios.
No, sir.
Yeah,
Sir, we have,
Pankaj sir, please comment.
yes. So I was saying this discussion is okay. I would just want to ask one more question. So just let's, for discussion's sake, consider this patient to be 55 and he wants to maintain his antegrade ejaculation. Then what are the options you have?
We have, sir, Urolift, prostatic urethral lift, but it is contraindicated in IVPP, sir.
It is contraindicated in?
Prostate extension into the lung.
Median lobe.
No,
It's
Median lobe.
not contraindicated. There are a lot of studies which have come up, which is called as median lift or mid lift, something by these names. They have come up with some studies where they can involve the median lobe and take it with one of the lateral lobes. So median lobe was initially considered as a contraindication, no longer considered, but yes, okay, Urolift. Anything else?
Then water vapor convection therapy, sir. Rhizome therapy. Then, sir, we have transurethral needle ablation and transurethral incision of prostate, sir. However, median lobe still is there.
Yes. What about ejaculation sparing TURP? Somebody has asked this.
Yes.
Ejaculation sparing TURP, sir, we leave a strip of tissue just proximal to the veromontanum, so that the chances of retrograde ejaculation is less, but it's still not foolproof, sir.
Yes. So it could be attempted, but cannot be guaranteed.
Yeah. Anil, bhai, you want to say anything?
Instead of talking
Yeah,
about tuna, you should talk about echoablation.
Okay.
Anil
Dr.
sir, sorry,
Udedar
आप
is there.
बोलिए.
Yes. I want to ask to Pankaj Maheshwari. Hello.
हाँ बोलिए sir.
How much mucosa you will keep just proximal to Viru to avoid retrograde ejaculation?
Sir, as per the literature, they say you should keep minimum 10 to 15 millimeters.
So 1 to 1.5 centimeters.
Yes.
That much mucosa.
Yes. So that
Yes.
much amount of tissue around the say paracollicular tissue needs to be left behind.
Yes. That we
So
are doing at present. We are
basically,
following
we
this
are
at
ending up leaving behind the apical lobes, which we normally want to resect in TURP.
Yes. And in small prostates, we keep the tissue or mucosa at 12 o'clock position. Just
Yes, sir.
0.5 centimeters or 5 millimeters to avoid bladder neck contracture in future.
Perfect, sir.
Yeah. So these two things we are following in our institute.
Fine.
Hello.
Yeah. So
yes, sir.
good. So can we go ahead
Thank
with the different cases now?
Yes, sir. Yes.
We are just going to give a short history. We'll ask the important investigations and the management of different cases. Okay. Paras, go ahead.
So scenario 2, he's a 66-year-old gentleman with lower urinary tract symptoms, IPSS score of 21/35, quality of life score 4, on medical management since 6 months, hypertensive, prostate is grade 3 on per rectal examination, non-tender, rectus mucosa is mobile, PSA is 2.6. The uroflowmetry suggests voided volume is 163, maximum flow rate is 13, average flow rate is 4 ml per second. On sonography, there is a prostate enlargement of there is marked prostate enlargement 191 grams with post-void residual volume of 61 cc.
Fine. Ajinkya, how will you manage this
Well,
patient?
so before I like to ask about what was his previous IPSS before starting the medical management.
Patient has presented to us for the first time.
This is the IPSS code and he is on the treatment.
What I didn't see. What was the prostate size?
191
191 grams.
191. It's too big.
So Ajinkya, what will you like to do? You will like to send the patient to someone else? You will like to do a medical line of treatment, or you will do some surgery on him?
Considering this IPSS score and whether the bothersome score, the patient is already on medical management for last 6 months, and see if there is we don't know the previous score, but if we ask the patient if there is still no improvement in his symptoms, I think I'd like to go ahead with some intervention with this patient.
So what will you like to do? Bhargav?
Considering the
Yes, sir.
So in institute, what you do?
Sir, open or minimally invasive prostatectomy, sir, in 191 grams prostate, sir.
So all three. What are the basic points to be considered before planning the treatment? So it is not only the size of the gland. Okay. So it is the configuration of gland. So intraprostatic extension. Is the median lobe present or absent? Yes or no? How much is inside the going inside the vesical region? That is again important. How much what is the severity of IPSS score? So mild, moderate, severe. How much is the PSA?
2.6.
How much is the bothersome index? So all these factors, is there any back pressure changes in the bladder, in the upper tract? Is any symptoms or signs of complication of BPS? So all these factors you have to think in one go and decide the type of treatment. So think yourself in this case and tell what you will do.
The duration of medical management he has undergone.
It's more than 6 months.
So, sir, this scenario particularly fits into the failed medical management, sir.
How much is the post-void residue? Here, in this patient.
60 cc, 61 cc.
61.
How much is the post-void?
61, sir.
How much is the pre-void? Only 61 knowing is sufficient?
Pre-void they have not mentioned, sir.
So you have to ask. If suppose it is a 1000 cc pre-void, what is important to that 41 cc?
Yes.
So you have to ask that. So that 41 or 61, whatever it may be, how much is the pre-void? And compare. If it is more than 1/3 of the pre-void, then it is significant. Knowing single post-void residue, again it is insignificant. Asking someone to pee in some demanding situation or condition, he may not pass comfortably. Na?
Yes.
But in this
So again,
patient,
IPSS score is 12 only, 12. In this patient, it is 12. He is taking the tablet. So what work he is doing, it is bothering to his day-to-day activity. Then again, that particular point you have to, this availability of treatment doesn't mean that you impose the treatment on that particular patient.
Yes.
Okay, so Ajay,
Yes.
this patient had a bothersome
4.
symptoms and the quality of life is affected.
Yes, sir.
Residual urine is 65 cc.
Yes.
As you can see, just show the uroflowmetry. What is the voided volume?
160 ml, sir, and Qmax is 13. Q average is 4, sir.
Yeah.
So
On an average, if you just
oh,
logically 60 cc and he is passing 160, so approximately the bladder volume, whenever he is doing sonography or all these things, must be about 250 cc.
yes.
Fine.
Yes.
So now 1/3 is almost his retaining beam.
Yes.
30%. And he has got a bothersome problem, symptoms. So what do you like to do now?
We'll offer him surgical management, sir.
So what you are offering?
Surgical management, we have to discuss with the patient. Considering the size of the prostate is 191 grams, we can opt for open surgeries or minimally invasive robotic surgeries or endourological surgeries. However, the open surgeries, we can remove the whole gland in one go. And if endourologically, it has to be done in stages, or it can be done robotically also. We'll discuss with the patient, sir.
So what about HOLEP?
OLEP also it can be done, but is time consuming, sir. HOLEP also can be done. It's parts of endourological management only.
Fine. So your choice will be what? First choice will be what you will offer to the patient?
Open prostatectomy, millions open prostatectomy.
Okay.
Millions.
Millions, yes.
Is there median lobe in this patient?
Median they have not mentioned, and
So Achin, before doing open surgery, you like to do something?
To do scoping.
Do a cystoscopy, sir.
Pardon?
For every open prostatectomy, we first do cystoscopy, sir.
Agreed. Doing a isolated cystoscopy for diagnosis of bladder outlet obstruction as per the guidelines, there is no role. But as a part of treatment, if you are doing a cystoscopy, like before doing the open prostatectomy or before doing the SULEP or HOLEP, whatever you are done, there is definitely a role to know the configuration of the gland, to know the intraurethral involvement of the or extension of the lobes inside the lumen, then to know the intravesical extension of the median lobe, how much is the median lobe, what is the length of the prostatic urethra, that all things, then then the complication in the bladder like diverticulum, any stone, any misroute malignancy, definitely there is role, but it is with planned some treatment.
Yes.
So Achin, what are the chances of missing any pathology inside the bladder with such a large prostate?
Large prostate will hinder the if you do transabdominal ultrasound with such a large.
While doing cystoscopy, what are the chances?
Ureteric orifice cannot. If there is a large median lobe, ureteric orifice could not be visualized, sir.
So even something behind if there is a large median lobe, you may not be able to see the trigone or anything behind that. Number one. Number two, if it is too big, your scope may not enter right up to the
bladder. We cannot. It might be impossible to reach the bladder.
Yeah. Dr. Maheshwari, you want to comment anything on this before we go to the other scenario?
No, I think so. They have covered everything well. So, like, if what are the various options you have? The options: open surgery, Millens, or Freyers. The decision of Freyers will be, this would depend on whether there is any intravesical pathology or not. You could do a two-stage TURP, but you should talk about the problems with two-stage TURP. Enucleation procedure by laser, whether holmium or thulium fiber, can be done at 190 grams. But as you rightly said, it needs expertise and it may take slightly longer period.
Correct.
And in today's time, for 190 gram prostate, laparoscopic oblique robotic simple prostatectomy is also one option.
Yes.
Yeah.
Yes.
सर ओपन प्रोस्टेटेक्टोमी के लिए कुछ और एक थोड़ा सा 10 मिनट का सेक्शन अलगली लेना पड़ेगा.
ठीक है.
How will you manage the bleeding? What are the ways of managing the bleeding? वो सब क्वेश्चंस कभी-कभी आ सकते. Paras?
Yes.
Please proceed.
This scenario is a 66-year-old gentleman with difficulty of passing urine since 3 months. The IPSS score is 22/35. Quality of life score is 4. Examination, general and examination is normal. Per rectal grade 3 prostatic enlargement. On investigation, urine culture is positive for E. coli, sensitive to piperacillin, cephalosporin, and nitrofurantoin. 10 to 12 per WBC per high power field. On blood investigation, PSA is 9.14, free PSA is 3.89, total PS free by total ratio is 0.384. USG is suggestive of 80 gram prostate with pre-void of 280 and post-void of 150 ml. Upper tracts are normal. What next?
Any treatment he has been taking for symptoms?
So in this case, let's discuss how will you evaluate a borderline raised PSA.
Yes.
So one is we already have the PSA ratio, the pre by total ratio, which is already 0.384, which is more towards the benign pathology.
Right.
Then I'll also like to have the PSA density.
How do you calculate PSA density and what is the cutoff values?
For PSA density, it is the PSA value upon the volume of the prostate. The cutoff value for PSA density is it should be less than the 0.15.
Yes. So more than 0.15, you will suspect malignancy.
Suspect.
Right. And say for discussion's sake, if this patient had a free by total of say 0.1, then what would be your next plan of action?
MRI. Considering the prostate is form in consistency, there is no hardness. First, we'll go for a multiparametric MRIs.
Right. And what do you expect in MRI? Means how do you interpret and how do you analyze the MRI report?
We'll specifically look for pyrite score, sir. If pyrites 1 and 2 are found, then there are very less chance of malignancy. Pyrites 3 and above, and the higher it goes, the more the chances of malignancy. If 3, 4, or 5 is found, we will go ask for trust biopsy.
Right.
Also, we will get to know if there is in MRI itself, if there is any very high doubtful lesion with extra prostatic extension, things like that.
Absolutely perfect. Anything more, Dr. Gite?
No, sir.
Any role for giving antibiotics and looking for drop in PSA?
Here in this patient,
Yes, sir.
Patient has culture sensitivity positive, sir. So we have to start him with antibiotics. He's already sensitive. Depending on the MIC value, we'll start with the most sensitive antibiotic. And PSA should drop. And also, sir, I needed to ask about the medical management. There is something called doubling time with alpha blockers. So considering the duration, if he's already on alpha blockers for more than 6 months, the corrected value of the baseline PSA would be will be cross the doubtful range between 4 to 10. So anyhow, we
I
have to
didn't
go.
understand what you're trying to say. What is the impact of alpha blocker on PSA value?
Alpha blocker, sir, decreases the PSA by half, sir. Over a
No,
period.
you are
You
mistaken.
are making wrong
5 alpha
statement.
reductase.
5 alpha reductase inhibitors. Sorry,
It is not alpha blocker, it is 5 alpha
5
reductase.
alpha reductase inhibitors.
Yes.
So if he's already on these medication for 3 to 6 months, so the PSA would be corrected. PSA value will be much more, sir. If it's 9 presently, it could be some 18. So we have straight away go for MRI, sir.
No, not exactly, because this patient has a culture positive thing. So
There could be
infection
infection
can
also.
raise PSA. Okay. So if clinically benign and culture positive, and especially if there are clinical signs also of say UTI or prostatitis, then a trial of antibiotic and repeat PSA. as it is in presence of infection, you would not do any biopsy. So you, as it is, need to correct the infection before you proceed any further.
Yes.
So in this patient, culture specific antibiotic for week or two, repeat the PSA. Still, if it is in gray zone, then go for MPMRI, check the period score. If it is 3-4, go for the biopsy.
Perfect, sir.
Next, Paras.
So MPMRI was done with the overall PIRAD score of 3.
So now, Ajinkya or anybody who wants to answer, do you want to do a biopsy? What do you want to do?
We'll like to go ahead with biopsy, sir. PIRADS 3 is borderline.
No, rather you see, at PIRADS 3 comes a role of PSA density.
PSA. Okay.
PIRADS 3 is a intermediate
Okay.
PIRAD score. So here will come a role for PSA density. In this patient, the PSA density will come very high. Kitna aega? 9 divided by what was the size of prostate?
80 grams.
नहीं, MRI में कितना बताया?
MRI में
MRI में
just
sir,
mentioned
size,
gross
gross
prostatomegaly.
Okay. So how much is the PSA density in this patient?
9 by 80 comes to around
Around
0.11.
0.11.
0.1.
So probably because it is PIRADS 3 and PSA density is low, biopsy may not be needed. Now, how do you really take into consideration the impact of dutastrides while calculating PSA density? This is something I'll need to check. I'm not sure about that.
Yes.
If there is, if he has a history of taking a dutastride for 6 months, and if you have corrected his PSA as it is 2.5 times more, then there should not be an impact. Now, if you already have corrected the PSA, then the division is as per that particular value, no sir?
Yes, so we will not need to take 9, we will probably need to take 18.
Yes, if he has already taken 6 month, minimum 6 month dutastride.
Yes, and if we take 18, then the PSA density goes very high, and that would bring it into a malignant zone or a say suspicious zone, not malignant zone.
Yes.
Yes.
So what was done?
Paras.
Yes. So trust-guided biopsy was done and there was no sign of malignancy. It was chronic prostatitis.
Yes.
So there are 3-4 questions in the chat box that we will resolve first, sir. One is as per the guidelines, when the combination treatment is taken for 6 months, the PSA should be multiplied by 2.5. I don't know, someone has placed 9 months and it is 0.5. I have not read till time, but it may be there somewhere else. I exactly don't know about that. Another question. Another question is why trust? Why not MR fusion?
See, MR fusion is not available at every place and MR fusion is not needed in every patient.
When purpose is solved by the trust, then why there is a need of MR fusion? So if you tried for trust and if it is failed to diagnose the malignancy and you suspect malignancy clinically or laboratory wise, then go for MR fusion. But at least primary trial with TRUS is definitely indicated before going for MRP.
Absolutely, sir.
Fine. So, Achin, what do you like to do now?
Sir, if patient is not on any medical management, firstly, I will start with, sir, medical management only, sir. I
He is
would-
already on a medical management. Show the uroflowmetry. Show him uroflowmetry.
Sir, wadded volume is 114 ml. That's less than 150 ml. So this uroflowmetry should not be taken into consideration. However, the flow is very poor. Qmax is just 3 and Q average is 1.5.
So now what we'll do?
Uh, patient IPSS score is
IPSS score is very high.
21.
21.
Can I see the MRI images again?
Yeah.
Images. Not the report, MRI images.
Images.
इसके पहले वाला. Yes, बस.
There is lesion in right side.
It's a big prostate.
80 grams. In USG.
There may be some,
Some
collection prostate. There
some
may be
lesions.
some pus inside the prostate. It appears like that.
But MRI not shown.
If you see these pictures, there is some lesion on both sides.
Yeah, but we have done the biopsy and it has turned out to be chronic prostatitis.
Okay.
So Bhargav, what do you like to do now?
Sir, in this
Answer fast
patient,
so that we can go ahead.
yes, sir, in this patient having a severe IPSS symptom score with bothersome symptoms, and patients having a urinary tract infection. So I would like to treat the urinary tract infection first, and after treating the infection, I would like to plan for the surgery in form of minimally invasive, in form of a translucent resection of prostate, either monopolar or bipolar DRP.
Okay, fine. Dr. Udedar, you want to add anything?
Oh, this is new.
I agree with you.
Fine. I think we should go ahead with the scenario 4. Paras?
Scenario 4 is a 68-year-old male with lower urinary tract symptoms, IPSS 17/35, grade 2 prostate enlargement, PSA of 1.1, no comorbidities. On sonography, prostate is 72 gram, pre-void is 366, and post-void residual volume of 300 ml. What next?
Fine. So again, Bhargav,
Yes, sir.
how will you proceed?
So I would like to assess for the bothersome symptoms on this patient.
So he has got no.
Bhargav, see the post-void residue
Residue is 300.
out of.
Yes, sir. It is significant post-void residue.
Renal function test is okay, and the upper tract is also normal. Someone has asked the question, so these are the answers.
Patient is in near retention.
So I would like to,
or maybe in retention.
sir, is he any taking any treatment for the prostate in the previously?
No, patient is on medical therapy.
On medical
Wake up from your chair and go and palpate the bladder. If you feel bladder is palpable, place the catheter. That should be the first action by you after seeing this report.
Yes.
Otherwise, giving alpha blocker with 300 post-word residue out of 350 or 360, then patient will be end up into the chronic retention, taking with multiple alpha blocker.
If you see it, you can always say that this patient is probably in a chronic retention because he doesn't have any pain.
No pain.
He is just telling
It's in
that
the
he is,
definition of chronic retention.
What, sir?
He fits in the definition of chronic
Yes, sir.
retention.
What should I say?
so now next what?
We need to rule out cause of chronic retention, sir. A urodynamic study should be indicated in this patient.
When?
Post-word residue is 300 ml, sir.
No, so you want to first do urodynamics before putting in a catheter, or put in a catheter and do urodynamics later on?
Nice,
So
sir.
putting a catheter, wait for 1 or 2 weeks, and then plan urodynamic studies.
So, Ajint, what do you want to do?
Same, sir. Same. First, we will put the catheter, we will stabilize the patient, and later on, after treating any infection, if there is positive report, then we'll do urodynamic. There is no urgent need of any urodynamic seriously.
Fine. So we did the same thing and we did the urodynamic. Show.
Can we have the filling phase here?
Anyway, we will give you the report. Just read out. Paras.
Urodynamic study, sensation are present, anal tone is diminished, voluntary contraction of sphincter is absent, bulbocavernous reflex is absent, post-void residual volume of 400 ml with leak present 140 ml during the test, bladder capacity is large, compliance is low, precursor is acontractile, pdet void is 3318 centimeter of water. Sphincter is decentralized, denervated. Urethral closure mechanism is normal with raised pressure at the bladder neck. Cuff stress test is negative. Overall impression is neurogenic vesico-urethral dysfunction.
Go back to the graphs, please.
To the graphs. Bring it in the center, Paras. In the center. Yeah.
So you can see that there is hardly any detrusor pressure generated on prolonged filling. And whatever changes in the graph that you see are all abdominal
pressure
transmitted to the bladder.
Correct. Fine. So what is the literature is saying and what you like to do, Achin?
Sir, as per the literature, acontractile bladder, if we go for any kind of surgery, it won't serve the purpose because patient won't be able to pass because of the detrusor acontractile. However, we have noticed that even if acontractile bladder, if we go for TURP, people do pass urine a little less and may require longer catheter placement post TURP and afterwards CISC. So we can do.
Before telling TURP in this particular patient, you should be very cautious. practically as well as theoretically. That means in front of patient as well as in the exam. Because this bladder is totally contracted. So you should start with some treatment with self-clean intermittent catheterization, like relaxing his bladder by alpha blocker, try to improve with tone with cholinergic drug, may helpful, may not helpful theoretically, hypothetically, but you start this drug, cholinergic drug plus alpha blocker plus self-clean intermittent catheterization plus culture positive antibiotic, if it is culture positive antibiotic, and reassess periodically.
See, there are two things. One, that all the patients may not compile with the CIC. And second thing, if there is an enlarged prostate, it may be little difficult to do it regular basis, like 3 or 4 times in a day. And it may cause infection or it may cause some trauma. So considering this, Achin, what are the options open?
We'll explain to the patient, sir, that there are two different lines of modalities available. One is we ask him to go ahead with CISC alone, and then periodically assess. Or the second line is we go ahead for the surgical management along with suprapubic stomy, sir, in the same setting, and then we remove the peripheral catheter later and allow him to pass urine, and depending what is the post-void residual he is remaining behind, that can be drained by SPC route or by CSC if we have not done SPC.
I've got some suggestions for you here, Achint. You see, when you are giving it, talking in exam, don't talk of TURP unless the examiner pushes you to talk about TURP.
Yes.
Okay, just say that patient has a contractile detrusor. For patient to pass urine, I need deobstructed passage and a contractile bladder. So I will either put the patient on CIC or SPC and wait. How long do you want to wait? You can easily wait for a period of 3 months. How would you clinically know that detrusor contractions are returning? There are a couple of things you would look for: whether patient has any bladder spasms, whether patient has any pericatheteric leak, or whether patient has any voiding sensation. If these 3 things are there, then probably that's a sign of return of detrusor contractions. And this is the time you may repeat a urodynamic test. And in exam, I would say that I would do a prostatectomy only after the return of detrusor function and stop here. Now let the examiner ask you, is it possible to do TURP now? Okay. And that is the time you say that yes, it is possible, explaining the patient very well that it is possible that post-op also he may not be able to pass urine, but a lot of patients will be able to pass urine because of your surgery and because of abdominal compression that he uses to empty his bladder. And further, as sir was just mentioning, Gaurang Shah sir was mentioning that TURP would also help, that probably CIC would become easier. And the last question here will be whether you want to do a resection or enucleation procedure. Definitely, if you are operating a patient who has underactive or a contractile detrusor, enucleation procedure is better than resection procedure because the urodynamic parameters are better improved with enucleation than with resection procedure. So what form of enucleation you do depends on what facilities you have. But in this situation, enucleation has an advantage over resection. So from exam point of view, do not talk about TURP unless the examiner pushes you to talk about it. Dr. Gite, you want to add anything?
No, sir. I already make my stand on TURP. So initially, no one should give TURP as initial answer. So if I, as a student in exam, I will explain the patient about need of the self-clean intermittent catheterization. I will try to relax the bladder neck with alpha blocker. If size of the gland, then with combination treatment. That cholinergic drugs may help, may not help theoretically, but I will start cholinergic drug in terms of Urovoid or whatever the market name, that is
Bethanacol.
Bethanacol or Carbachol. And I will reassess the patient clinically, whatever the ways you told already, that is pericatheter leak or any sensation about the feeling the fullness of the bladder. and again go for the urodynamic study, reassess the urodynamic parameter. And after that, if it is improving, then may consider or may not consider for TURP. As far as PUC and SPC is concerned, if you are expecting the need of catheter for longer time, the SPC is always better than the PUC because that question is asked in the chat box. So SPC is preferred whenever there is a chances of having a catheter for long time.
Fine. So after considering all these things, we explain it to the patient and patient expected. So, but in the exam, students, whatever Dr. Maheshwari has said is a perfect answer. However, in practice, you can have both the things. You can decide on your own. You can do TURP and suprapubic catheter, or you can wait and repeat urodynamic study. And when you think that patient has got some contractions of the bladder, you can go ahead and do TURP. So we did TURP. What we have done?
We did TURP with SPC. Perurethral catheter was removed on post-op day 5. Patient was sent on SPC. SPC clamping was start after post-op day 10. Patient used to intermittently drain urine and measure the post-void residue by opening the SPC catheter. Gradually, the PVR was decreased and SPC was removed after 2 months.
Yes.
Right. This is what we have done. But whatever Dr. Maheshwari and Dr. Gite has said, that is the answer in the exam. Fine. Go ahead. Last scenario.
So this is the last scenario. This is a 60-year-old male presented with lower urinary symptoms. Patient has on and off history of passage of blood in urine since 3 days, which is incomplete, present at the terminal part of urination associated with suprapubic pain, passage of amorphous clot, and is associated with burning during urination. There is no history of any anticoagulant intake. The blood parameters are normal. PSA is 0.78. As the sonography is as so.
So this is a sonography. Bhargav, you want to comment on this one film?
So there is a hyperechoic lesion with a post-acoustic shadow, mostly bladder stone.
Anything on the prostate?
Enlarged, there is enlarged
Can you see the
prostate
median
with
lobe?
median lobe. Yes, enlarged prostate with the median lobe.
So the sonography was suggestive of a 3 centimeter bladder stone with a prostate of 69 gram. Pre-void was 456. PVR was 220 ml. Should we do a uroflowmetry in this patient?
So now let's see what you will do. How will you proceed? Ajinkya.
Yes, sir. I'd like to do go ahead with uroflowmetry, sir. Here.
Pardon?
Yes, sir.
I'd like to go ahead with uroflowmetry, sir.
Uroflowmetry
Want to do
will show some
uroflowmetry?
falsified results.
Paras, we have done uroflowmetry.
If the bladder stone was there, so we didn't.
Okay.
What is the role? It is indicated, contraindicated. Dr. Udeda, Dr. Maheshwari, can you just advise?
You see, doing a uroflowmetry will not change your treatment plan in this
Treatment
patient.
plan. Yes, yes.
And furthermore, because of the bladder stone and bladder stone intermittently blocking the bladder outlet, the uroflowmetry may be fallacious.
Fallacious. Correct.
So because neither it is going to help me nor it is going to help me take a decision and report may not be good. So then why do it?
So
in this patient, you have clear indications of a large prostate with large median
exactly.
lobe, associated bladder stone,
Bladder
associated significant PVR, associated significant LUTS. How will uroflowmetry change your treatment plan?
Understood? Because there are all indications that the stone is secondary to enlarged prostate.
Yes.
So now next what? Achint,
So we have to tackle, sir, bladder stone. If patient has two problems, sir. Patient has bladder stone also. Patient has bladder outlet obstruction due to enlarged prostate also. So we have to tackle two different things in one surgery, or probably two different surgeries. So we have to offer him surgical management. So it can be done in the same setting via cystolithotherapy with the TRP, or it could be done open surgery, Freya's transvesical simple prostatectomy with the bladder stone removal, cystolithopex.
Achint, there are multiple permutation combination situations with BPH and stone. So large prostate, large stone, large prostate, small stone, small prostate, large stone. So each, and you have to think, can you able to tackle both situation in one go? BPH, like small stone, small prostate, yes, it can be done. 100-gram prostate, 4 centimeter stone. Can it be taken? So better to stage, na? What is wrong in that?
Yes.
So I will tackle first stone with PCCL, cystolithotripsy, according to the various factors. I will decide the treatment type of treatment for stone, clear the stone, then go for prostate. Again, it is depend upon the size, availability of instrument, experience.
Yes.
So, in the exam, any person will check your concept, not your theoretical knowledge. You should be safe to the patient. If you do a surgery for 5 hours, then it may end up into the danger to the patient. Na?
Yes.
So 3 situations: small prostate, small stone, PCCL, oblique cystolithotripsy with TRP in one go. Large prostate, large stone, stage the procedure, either PCCL, cystolithotripsy, open cystolithotomy for stone, stage TRP, bipolar TRP, laser prostatectomy for prostate. Then large prostate and small stone. Third. So if it is possible for you, if you have that much experience, go ahead in one setting. Otherwise, remove the stone with cystolithotripsy and go for prostate. Khatam. Same thing like CA bladder. Again, another situations. Big bladder tumor, big prostate. Small bladder tumor, big prostate. Small bladder tumor, small prostate. Resection in one go, resection not in one go. Indications, any contraindications, incidence of shedding, ये questions ये prostate के साथ आने वाले हैं. जो आपने जहाँ सेंटर है वहाँ पे अगर ऐसा कुछ अवेलेबल है तो रखेंगे वो.
Yes.
सर म्यूट है सर, आपका म्यूट है.
Gaurang Shah, sir, आप mute है.
See, it is not a very large prostate, like more than 80 grams or something. So you can say that one of the treatment is you go inside and see if the stone is soft, you do the cystolithotherapy, and then you can do the resection, or you can do percutaneous cystolithotomy or treaty, okay, and do TRP. Or the last thing is, when you go inside and say it's a big prostate, you do flares and remove it.
Yes.
Otherwise, all different permutation combinations are there. Dr. Maheshwari, you want to add anything?
No, sir. I think Gite sir has covered it very well. So you can choose whatever option you want, stick to it, and explain why you have chosen that option.
Exactly.
Sir, one doubt, sir. In last scenario, shouldn't we just tackle the stone problem first and then reassess the patient for whether there is a need of TRP or we can do with medical management?
What last scenario means? The last case you are talking about?
Last
Yeah.
case. Yes.
You see, he had a very large median lobe and significant post-void residue and significant obstructive symptoms. So my decision will be based on these 3 things. So if this patient comes predominantly with storage symptoms, then probably what you are saying is right. But if he also has a significant voiding symptoms, then this is a patient who is probably heading towards the need for prostatectomy.
But sir, having a stone of 3 centimeter in bladder, so you can how can we be dependent on whether it's storage symptoms or voiding symptoms?
So if you are in doubt, stop and reassess is always option.
Okay.
But Achin, what are the chances of 3 centimeter stone coming and obstructing the bladder neck, and patient having 220 cc and having a large prostate? Still, sometimes we have to think little logical. You understand? Everything, every time we should not go by whatever, different things are given in book. Books are why we are covering all these things, so that you come across in practical life. We are coming across so many different scenarios, and you have to take some decision.
Yes.
Achin,
Yes.
whenever you are planning to tackle the stone, because BP in stone, both large prostate, large stone, you have to tackle stone first.
Yes.
Okay. So you have to go, you are going inside for stone. Check endoscopically. Is both lateral lobes are occlusive or not occlusive? Median lobe is too much inside the bladder or not too much inside the bladder? What is the prostatourethral angle? Is bladder neck is highly overriding? Is there are associated trabeculations, diverticulations? This picture is suggestive of the prostatic obstruction. If you remove the stone, you don't remove the stone, you have to treat the prostate also. So when in combination, if such situation seen on endoscopy, you treat the stone first and treat prostate later on. If you feel there is a non-occlusive prostate, give the medical treatment and trial widening or reassess.
Yes. Yes. Yes.
I think Dr. Gite, Maheshwari, and all has covered all the different scenarios very nicely. So in exam, if you get different cases, you will be able to answer.
Yes.
Fine.
So, sir, I am talking from a remote place in Nanded district. Some small taluka place, my native place is there. I
But
already know.
compared to your Aurangabad, the Wi-Fi is better over here. So, so I'm so glad that today Dr. Udedar also joined, and Dr. Maheshwari, as usual, has been very informative and very practical. So you have learned a lot how to answer in the exam. This is the best thing you have to learn from Dr. Maheshwari. So thank you very much. I thank all the students for participating in a very big number, and I wish that all of you please consider this as a very important aspect, or one of the important clinic in your life, and please attend in a big number.
Pankaj sir is guidelines of our class.
Yes. Okay. Good night
Thank
to all of you.
Good night.
Thank you,
Thank
sir.
you.
Thank you.
Good night. Good night.
Thank you.